Good morning. My name is Gary Greenswag. Welcome to our grand rounds for September 20th. We are very happy to have you here this morning, and we're happy to have our guest speakers to talk to us about screening and management for osteoporosis. This work has been 8 to 9 months in the making. Is that about right? Where we've had a team of folks come together from across the system. You're going to hear from two of our leaders this morning, and who I'll introduce in a minute, to kind of talk about and figure out what we can do to standardize both screening and management for osteoporosis. I don't think there's a special month, Osteoporosis Month, that we're in, but nonetheless, we're happy to bring you this information and hope that it spreads across CommonSpirit Health, particularly in the area of primary care, and certainly for specialists as well. So I am going to take this opportunity to introduce our panel, and then we'll get started. So first, we have Dr. Kavita Chawla, who is a general internist practicing at Virginia Mason Medical Center in Greater Seattle. She is passionate about elevating primary care with a particular focus on advancing the practice of evidence-based medicine. As the Director for Evidence-Based Medicine Education in the Department of Primary Care at Virginia Mason, she leverages clinical spotlights and enhanced workflows to empower her primary care colleagues in practicing evidence-based medicine. And we also have Dr. Brian Jang, who is an assistant professor at the Baylor College of Medicine. He is a native Houstonian who joined the Baylor endocrinology faculty in 2017 after completing a residency and fellowship training at the Baylor College of Medicine. He is a clinician educator who holds special interests in quality improvement as well as treatment of metabolic bone diseases such as osteoporosis. He devotes the majority of his time to seeing patients within the Harris Health System. And last, we have Ann Wright, who serves as the Assistant Director of Advanced Practice Ambulatory Care Operations for CommonSpirit Health. Ann has nearly 30 years of working in healthcare, over 20 of which have been as an advanced practice provider, with the bulk of her clinical experience as a physician assistant in orthopedic surgery. And of course, we have Dr. Sagar, who will be leading our panel. We have Rachel Bates with us this morning, and John Kanishi, who's running the show, I guess. So with that, Kavita, we'll turn it over to you, and thank you very much.
All right, thank you for that great introduction, Gary. It's a pleasure to be here this morning. So this Grand Rounds is to help socialize the recently published CommonSpirit Health guidelines on the screening, diagnosis, and medical management of osteoporosis. These guidelines were created by a multidisciplinary work group organized by the Clinical Standards and Variation Reduction team, led by Dr. Greenswag and Dr. Sagar. And just here's a table of contents to give you an overview of what these guidelines cover. So why now? Why tackle this topic now? So in the past 5 years, all the major professional societies have published updated guidance on screening and management of osteoporosis. And so we incorporated all of the guidelines listed here into our national CommonSpirit guidance. Our learning objectives for this morning, I always believe in starting with the why. Why is osteoporosis important? And really understanding the impact it has on our patients' quality of life. Understanding the what is required to make a diagnosis of osteoporosis. We will understand who should be screened, followed by the how. How do you treat it, monitor it, follow it? And finally, when should a primary care clinician refer to an osteoporosis specialist? Okay, so I know I learn best when I answer questions, and especially when I get the answer wrong. So we have peppered multiple choice questions throughout the talk this morning to level up your learning experience, starting with question 1 here. So please engage and answer with it as we go along. Which of these are true regarding osteoporosis worldwide? The annual incidence of osteoporosis-related fractures is higher than the combined incidence of myocardial infarction, prostate cancer, and breast cancer. Or B, about 1 in 2 postmenopausal women will sustain a fracture due to osteoporosis during their lifetime. Or C, a vertebral fracture is associated with a 5 times higher risk of another vertebral fracture. And select all that apply. Excellent. All right. I like the split here. So turns out these are all true. And I think that is what is so sobering about osteoporosis. When you look at the numbers, it represents quite an illness burden on our patient population. So nationally, osteoporosis is responsible for an estimated 2 million fractures a year. Yet only 80 or nearly 80% of older Americans who do suffer from fractures are not tested or treated for osteoporosis. 1 in 2 women and up to 1 in 4 men over the age of 50 will have an osteoporotic fracture. So for women, that translates into higher incidence of osteoporotic fractures compared to the combined incidence of MI, breast cancer, and stroke. Economically, it's a large burden on the healthcare costs as well. As of like 2025, which is around the corner, the annual costs related to osteoporosis are estimated to be $25 billion to the US healthcare system. But like, let's zoom into the patient and the burden that the patients carry because of this less recognized condition. When they sustain a vertebral compression fracture, they are at risk for a 5 times higher another compression fracture within the next few years. And of course, the associated chronic back pain and higher mortality. And then hip fractures are particularly disabling because 1 in 2 who experience hip fractures will not return to their previous level of function. As you can see from this little pictograph here, in the general population, about 1 in 100 will be wheelchair bound due to health conditions. But you compare that to individuals who've sustained a hip fracture, and 1 in 4 will be wheelchair bound. So quite a major illness burden on our patients from osteoporosis, which is why it is absolutely in our purview and high priority for us to identify and diagnose and treat it. Okay, so what is osteoporosis? So when I talk to my patients about it, I talk to them about good bone health is harmony. Harmony between the osteoclasts, which are the cleaving cells of your body. They cleave away the old bone versus the osteoblasts. They're building up the good bone. But when your osteoclasts outperform your osteoblasts, that is osteoporosis. And this also helps the patients understand when you start talking about pharmacotherapy, which side of the equation are those medications working on. Clinically, though, the guidelines do give a more specific definition of osteoporosis. So if the patient meets any of these 3 criteria, that is diagnostic of osteoporosis. So, of course, if the bone mineral density is 2.5 or more standard deviations below the peak bone mass, which is basically the T-score of -2.5, that is osteoporosis. But also, if the absolute fracture risk is 20% or more over the next 10 years using the fracture risk assessment tool called FRAX, then that is osteoporosis. Or, and this is important, if they have sustained a fragility fracture at the hip, the vertebrae, the humerus, the pelvis, anywhere, and by fragility fracture, we mean it's a low trauma fracture, that by itself is diagnostic of osteoporosis, regardless of what the bone density shows. So capture the fracture. If you see a fracture, you have to investigate it further. And so for all my primary care colleagues, I will call out a tip to make sure at that annual wellness visit every year, you are checking their height. Take those shoes off and check their height, because over time, if they have had a height loss of 1.5 inches or more, you want to get a lateral spine x-ray to look for occult vertebral fractures, because that would be diagnostic of osteoporosis. So here's the algorithm that we have included in our guidelines for making that diagnosis of osteoporosis. It's kind of busy, but what we focused on with the diagnosis of osteoporosis is listed right here. So any kind of fragility fractures, if the 10-year risk is 20% or higher, or a T-score less than 2.5. All right, question 2. Let's meet some of these patients. We have Miss Crackleton, a 63-year-old woman who is here for her annual exam. She wonders, when should she get a bone density scan? She has no family history of osteoporosis. She drinks 2 to 3 drinks of alcohol per week and is a non-smoker. She is on losartan for hypertension. How do you guide her? You say, okay, yeah, thanks for bringing it up. Let's proceed with a DEXA now. Or encourage calcium through diet and vitamin D supplementation, as well as balance and muscle strengthening exercises, but defer the DEXA until age 65. Or DEXA now because she's had a longstanding diagnosis of hypertension. Or just wait until she actually gets a fracture, then do a DEXA. Excellent. All right. Most of you got this right. Yes. So that's absolutely true. Who should we be screening? So she's 63. So who should we be screening? So the United States Preventative Services Task Force, USPSTF, put out their recommendation in 2018, and most national guidelines are pretty aligned here. It's a grade B recommendation to screen all women over the age of 65. And if you're under the age of 65, then if you have certain risk factors, then you should be getting screened. Just a point to note that the USPSTF is in process right now to update this recommendation, and that'll probably get published by the end of the year. But we don't really expect any major deviance from what we're discussing today. Okay, so who do you screen? So for sure, women over the age of 65. But if they're under the age of 65, there's a whole bunch of conditions that can put you at a higher risk. This is a long list here. So the ones that I will bring to your attention, beyond the ones that you typically see on that FRAX risk tool, right, is if they have had a low BMI for a long time, their bones haven't been carrying much weight. So a BMI of less than 19, you should be getting an earlier DEXA scan. For sure, if they've had any kind of low impact fracture, as we discussed, they should be getting evaluated sooner. If they've had a long-term use of insulin, so type 1 or type 2 diabetes, that puts them at risk. Premature menopause is often missed. So menopause before the age of 45, surgically or otherwise, puts them at high risk because of that absence of estradiol for prolonged periods. And then various malabsorptive symptoms, but a key one that we often miss is Roux-en-Y bypass, because remember how the stomach is all gone in that compared to a gastric sleeve. So even though these individuals may be on the other end of the BMI spectrum, they are not absorbing calcium and vitamin D well, and that's why they're at higher risk for osteoporosis. Okay. How do you screen? We know DEXA. I've said DEXA a few times now. So that is the preferred method of screening. You want to get the axial, so that's the lumbar spine, and the non-dominant hip. But for the baseline, if you can get both hips, that would be great, because eventually a lot of these patients do go through hip replacement. There will be times when you should add on a forearm DEXA, and that is if the patient has hyperparathyroidism, if they have advanced arthritic changes in the lumbar spine, so that falsely elevates the bone density, or if they've had bilateral hip replacements. Okay, I want to take a minute here to talk about calcium and vitamin D, because we're going to talk about a lot of the fancy medications that are available, and they are great. But if we don't take care of the fundamental needs to maintain bone health, which include calcium, vitamin D, and exercise, and really, as primary care docs, spend time in counseling our patients about this, all of the rest is moot. Doesn't matter, because they will not really get the benefits that they need from the medication. So for calcium, we know the recommendation is 1,200 milligrams a day. So that's widely known. But what I would emphasize is we want to try and get most of that calcium from their diet. It is much more bioavailable than calcium from supplements, which is why I love this calculator from Osteoporosis Canada that helps a patient calculate their own daily dietary intake and helps them understand if they're actually meeting the mark of the 1,200 milligrams. Here's an example calculation on the right. So if they're not meeting it, like this patient still needs to increase their calcium intake by 300, they can either use that same website to come up with ideas of calcium-rich foods that they can introduce, or if it's really not possible to increase calcium-rich foods, you can supplement. But the point here is not everybody needs calcium supplements, and certainly not all of 1,200 needs to come from calcium supplements, ideally not. Vitamin D, now that one is harder to get from food, so that is typically through supplements, and we do recommend maintaining a serologic level between 30 to 50. And then exercise. So the goal here, of course, is you want to keep putting that load on the bone as well as prevent fractures. And so weight-bearing exercise most days of the week, plus muscle and posture or balance strengthening exercises 2 to 3 times a week. Again, I love this resource that's listed here because it really meets the patient where they are at their fitness level and helps them get stronger over time. So lots of great ideas and guidance at this website. Oops. I didn't mean to click on the website. If you smoke, please stop because that is absolutely eating away at your bones. Alcohol use in excess, so 3 or more drinks a day is dissolving your bones. And so that's something we have to spend time counseling on. And then fall risk reduction, again, taking a moment to do a root cause analysis of if they have had multiple falls, what's the cause there? Do they need vestibular physical therapy because of balance issues? Or is it that they haven't had eyeglasses updated in the past 4 or 5 years? Or is it due to diabetic neuropathy and they need a podiatry referral to get orthotics for their shoes? So really spending the time to understand why they are having recurrent falls. Okay, question 3. Ms. Crackleton is back 2 years later for her annual exam. She is now 65 and she recalls you recommended a bone density scan this year. DEXA now shows a T-score of -2.6 at the spine. Her comprehensive metabolic panel, vitamin D, TSH, and parathyroid hormone levels are all within normal range. So you recommend initiating treatment with alendronate, zoledronic acid, denosumab, abaloparatide, or romosozumab. Look at that, you hit that out of the park. That's right. Most of you chose alendronate, and I would agree with that. So here's the algorithm that is in the guidelines on how to treat osteoporosis. I will focus on the left side of the algorithm here, which is that primary prevention of osteoporosis. So you haven't had any fractures or you don't have severe osteoporosis. Absolutely. By far and away, bisphosphonates are the first line for treatment of osteoporosis, and you will typically have them on this treatment for 5 years. But Ms. Crackleton is not happy with your recommendation. She's not interested because her friends have tried it and they've had bad side effects. Her husband is also a dentist and has said alendronate is bad for her teeth and it's going to rot her jawbone. So she's heard this thing Prolia, and that's what she wants to start. How do you counsel her? You say, that's fine. Any treatment you're willing to start is the right treatment, so let's start denosumab. Or educate her that denosumab actually has an equivalent risk of osteonecrosis of the jaw as alendronate and other bisphosphonates. Or denosumab is inferior to bisphosphonates in fracture prevention. Or D, both B and C are true. I love this split. Okay, we're kind of distributed across the answers, but B and D taking the lead here. So indeed, it is both B and C are true. So there's a lot we have learned about denosumab in the past few years, and that's actually a major call out in all of the national guidelines that I listed at the top of the hour. So for sure, denosumab is great at treating bone density, and especially in patients with chronic kidney disease. It is safer, right, than bisphosphonates. However, please be aware that that risk of hypocalcemia when you initially start denosumab is very high in these patients, and that's why you do want to monitor them very closely. The issue, however, is, so denosumab is an injection every 6 months. If the patient misses that interval, and it's been more than 7 months since the last injection, they are at high risk for multiple vertebral fractures because of that withdrawal. And this is why you can't really have a drug holiday from denosumab. If you're going to stop denosumab, you do need to transition the patient to some kind of anti-resorptive treatment, ideally bisphosphonates. So that is also part of your initial counseling when the patient gets on denosumab, that, hey, eventually you will still have to get bisphosphonates on board. Or if the patient has advanced kidney disease and they can't have bisphosphonates, raloxifene would be kind of a backup option. Now, the other aspect to remember is that denosumab is associated with a high cost of denials. There's very specific documentation that has to be in your clinical note. And most Advantage payers also require a prior authorization for the year, every year that you're going to prescribe denosumab. And so as a result, a lot of institutions eat the cost of these shots, which, by the way, each shot is about $6,000. So think about how many of your clinic visits get wiped out because of one denosumab denial. So there are lots of issues here to be aware of before you prescribe denosumab. And then osteonecrosis of the jaw. This issue has been put to rest by American Dental Association. The links are listed here. There was a multidisciplinary task force that put forward these recommendations that, yes, while there is a risk of osteonecrosis of the jaw, it is rare, 1 in 10,000 to 1 in 100,000, compared to the potential reduction in fractures from bisphosphonates of 40 to 70%. And so if you have a dentist who is really concerned about your patient being on bisphosphonates, this link here takes you to a template that you can use to communicate this risk-benefit discussion with your dentist. I have found it very useful because I certainly continue to have dentists who bring up this concern. Okay. With that, I'm going to hand it over to Dr. Zhang to review the more severe cases of osteoporosis.
Okay, thank you so much. So let's talk about a different patient. So let's talk about another lady, a 71-year-old lady, Miss Fraxer, who is presenting to you now with a recent history of 2 acute vertebral fractures that she recently sustained after falling, at the ground level. So a DEXA scan is ordered, and it shows a vertebral T-score of -1 and a femoral neck T-score of -2. So how do you want to proceed? Should we do oral lendronate, IV zoledronic acid, start denosumab, recommend non-pharmacological therapy, or potentially refer to endocrinology for initiation of anabolic treatment? Okay, I like the spread here. Yeah, okay. So in this case, we would actually refer to endocrinology for initiation of anabolic treatment, and we'll get into kind of the ins and outs of why. So before we do that, I just wanted to make sure that everyone is aware that when we've been talking about this idea of fragility or low impact fracture, there actually is an actual definition to this. So Osteoporosis International is kind of vague. They just say a fracture resulting from mechanical forces that would not ordinarily result in a fracture. But WHO has later clarified this, and they basically now say that it's the force equivalent to a fall from standing height or less. And in my experience, it's actually our ortho colleagues that are the absolute best at this. They practically have this down to like a GLF is literally an acronym they use, or ground level fall. So always just remember that phrase, ground level fall or less is the amount of force, and that should not cause breaking of your major bones. Now, just as a reminder again, we're looking at the far right of this treatment algorithm. Okay. And then we're also now, instead of looking at the left side of the treatment algorithm, we're now looking at the right side of the treatment algorithm. And because this person has recently suffered a severe vertebral fracture, then anabolic therapy is probably a good thing to at least assess for. Okay. Now, anabolic therapy does have a lot of considerations, and this is why the algorithm really says to at least really consider a consultation here. For one, it's reserved for the highest risk patients who have clinical history of multiple vertebral fractures, occasionally hip fractures as well, after those low impact trauma. There's a lot of caveats. The duration of treatment is only 1 or 2 years, and patients should always transition to anti-resorptive therapy after completing anabolic therapy. So there's no such thing as saying the person refuses anti-resorptive treatment, therefore I'm going to be doing anabolic therapy. They have to know upfront, otherwise they're just going to simply lose everything that they gained. Now, I think people could have argued that the last question we had, starting alendronate and then referring to the endocrinologist would be a decent idea, right? At least give them some sort of protection until they can see the specialist. I've had a lot of PCPs try to do this, and unfortunately, that actually can hurt our cause here. So it turns out if you start an anti-resorptive agent and then transition to anabolic agents, it actually blunts the improvement in their bone density. And so the sequence of treatment actually matters, and I'll go into that into a little bit more detail later. And there's currently 3 medications. Of the 3, the first 2 are, I would say, very similar. They're once daily self-injections at home, so a little bit cumbersome. And then we have a recently new arrival in romosozumab, which is a monthly injection in the clinic for a year. Now, I'm not going to go over all the details of this slide. All I really want to mention is that there's probably a lot of cautions, contraindications, and nuances to these therapies that before you start them, you have to really pay attention to. And so if you're not well versed in these medications, this would be another good reason why you would want to consider a consultation. But for the sake of time, because I think we're running a little bit behind, I'll just say that it is on there in our guidelines. However, if you're not comfortable with this, I do highly recommend at least going to a specialist who does this at least in decent volume. Now, we talked about how the sequence matters, and I just wanted to show this to you guys in graphical form. So looking at the newer medication, the newer med on the block, romosozumab, it turns out if you go sequentially, basically they were not on treatment before for their osteoporosis, and then they started on romosozumab prior to being on alendronate or denosumab, the anti-resorptive, then they get a nice about 13 to 14% on average BMD increase. That's basically in a year. And it turns out if they were on alendronate before, that response gets blunted by about 25%. And if they were on denosumab before the transition, it actually is blunted by about 50%. You can also see this a little bit more in a different way on the right side. There was a trial called the Data Switch trial, which took a look at people getting teriparatide and then denosumab, or the other way around, denosumab followed by teriparatide. And if you just focus on the green and the yellow lines, you can see how if you give someone denosumab first, and then you give them teriparatide, you get a much blunted response as compared to if you had done the opposite. And so it really does make a big difference. And so if possible, we would want to evaluate them up front, not just for the not just for starting anabolic therapy, but what happens afterwards. The patient really needs to be informed about the entirety of the process. So again, just as a reminder, why you should highly consider seeking a specialist if anabolic therapy is potentially on the table. There's just a lot of extra legwork in terms of the history taking and the workup that's ensured to require there's no contraindications to these therapies. Some of them still even have black box warnings on them. And then another thing is that the more commonly used ones, teriparatide and its analog abaloparatide, they can be actually pretty cumbersome for patients. You're talking about daily self-injections. And so a lot of times there's a lot of anxiety around this, and a lot of high volume osteoporosis clinics will actually do on-site teaching, and things like that, and even give them sample pens to, they can sample on themselves. And so this really helps with adherence. And then because they eventually have to transition, that broader discussion really needs to happen. In fact, if patients absolutely tell me ahead of time they're not going to transition, then we actually don't do anti-resorptive therapy. It simply doesn't work that way. And then lastly, similar to denosumab, these anabolic treatments are exceedingly expensive. You're talking things on the order of $2,000 to $3,000 a month. So it certainly is on the level of denosumab, and there is pretty much some very specific documentation that you might need. Now, other than starting anabolic therapy, when would you really think about seeing a specialist? And I want to start by saying this. These are not exhaustive by any means. Certainly, if anything you're not comfortable with, but the ones I really want to highlight are anyone who's in need of a drug holiday and they're on denosumab, who's really been unable to transition to bisphosphonate therapy, which the most common reason being their eGFR is under 30 or they have advanced CKD. A lot of these patients were put on it before we knew about some of these issues with denosumab, and now some of them are so-called stuck. And so what do you do with them? And then people who continue to fracture on active therapy, is it treatment failure? What's going on? Should they transition? Do they need secondary fracture risk assessment? And then people who have very low bone density, T-scores less than -3, and there's nothing obvious in their history, like they have sarcoidosis on steroids for a long time. These people may benefit from a more exhaustive secondary causes workup, diagnosed a number of multiple myolomas, celiac diseases. So just anyone where you're just like, something's really off about their bone density. And I'd like to finish off by just one more question about Ms. Fraxer. So say she sees the endocrinologist and she actually is offered romosozumab once a month subcutaneously, but she declines it because she refuses all non-oral therapies due to severe phobia to needles. So unfortunately, you decide to start her on alendronate. In this case, when should her next bone density scan be scheduled for? Okay, 1 to 2 years. So I think a lot of primary care doctors will be very happy to see what our recommendation on this is going to be. And we'll try to explain this. So actually, if you look at the third column, the expected change in bone density, and then the second column, the timing of bone density repeat, we're actually going to say that if they're on bisphosphonates or denosumab, it's 5 years. And the reason for that is you definitely want to get one at least every 5 years, but otherwise you really want to think about doing one when it's time to transition or when you want to make some sort of medical decision-making on changing either to a drug holiday or to another agent because they fractured. That tends to be when you want to do a bone density. And in terms of what's the expected change, I can't stress this enough because I get this a lot. Failure of an increase of bone density is not failure. Its stability is generally what we would expect as the minimum threshold. And so as long as they're not fracturing and the BMD is stable, we would consider this to be a successful therapy. Now, a tip that I'll go over in the next slide, but very, very important. One thing you can help yourself out a lot on is take the time and make sure that when they get their follow-up bone density scan, that it's at the same location that they got their previous density scan. And if they can't do that, at least make sure it's on the same machine or the same type of machine. And in terms of the frequency, just as a reminder, while in pharmacological therapy, you pretty much want to repeat it at time points when you may or may not decide to adjust. Otherwise, every 5 years is reasonable. And in the case of alendronate, because most uncomplicated patients without fracture will be on drug holiday after 5 years, the 5-year mark is reasonable. Now, if they're on active drug holiday already, we recommend it for every 3 years. And if they don't quite meet the criteria on the initial screening and you're just following up, then it's anywhere from 3 to 5 years, just depending on their risk factors. Now, why is it such a big deal to make sure that you need to be using the same machine whenever possible? So if you've ever actually looked at these detailed DEXA reports, if they have actually had multiple DEXAs saved on the same machine, you'll actually get a plot of every single prior DEXA, and then they'll actually show you the statistical significance and the change from baseline and the change from previous. And this data is pretty much invaluable. In fact, this is the data that we would actually use for decision making, not T-scores and Z-scores. And if you use a different machine, then none of this actually will show up. Even if you actually have the old data, like they bring in the old data and you try to manually calculate it, the validity of actually manually calculating it is still questionable when you in terms of decision making. So always make sure to use the same machine whenever possible. So just as a couple take-home points, biggest thing, if there's anything that you take out of this, look at clinical history of low trauma fractures, especially for the hip and the spine. You can diagnose patients simply by clinical history. Otherwise, DEXA and FRAX score can also be used for diagnosis. Weight-bearing exercise, along with dietary calcium and vitamin D intake that's adequate, is absolutely critical. Every single trial that we've done on these pharmacological medications, all patients were basically screened to make sure they had adequate calcium and vitamin D intake. Bisphosphonate therapy, at the end of the day, it remains the mainstay of osteoporosis treatment, despite all the shiny new medications we've come up with over the years. So all your anabolic agents and denosumab, they all ultimately still require transition, if possible, to bisphosphonate therapy due to bone loss when you stop it abruptly. And then lastly, what we just mentioned, bone density should always ideally be performed using the same machine whenever possible. And then I think we're ready for our panel.
Perfect, thank you. So we can pull the slides down, and I recognize we've given our panelists and our speakers this morning quite the challenge to boil down something that is a very complex topic, multiple moving pieces to it, and evolving. So thank you for your attempt in trying to get it down to those pearls of wisdom and nuggets of knowledge. So we have tons of questions from the audience member, and I think a good place to start will be a term that we've mentioned a couple of times in the guidelines, and something that all of us who were on the guidelines group, the clinical work group, had extensive discussions around: do we keep it? Do we remove it? Do we keep it? Drug holiday. What's the bottom line? Are we using the term, or are we redefining the term and reclaiming it for a different purpose? So I'll go first to Dr. Chawla, Dr. Zhang, and then Anne.
Yes, so drug holiday, very much still being used, and we do use it in our guidelines as well, with bisphosphonates, because of the risk of increased atypical fracture If you use it for typically longer than 5 to 6 years, that's when we recommend it, except for zoledronic acid, where 3 infusions typically gets you there. So that's when we would consider a drug holiday. But for all the other ones, as Dr. Zhang has explained, anabolic treatments all need, and denosumab all need to be transitioned to something else. So there's not really a true drug holiday there.
I would actually even be more thorough in this, and I would just say drug holiday refers to a holiday from bisphosphonate therapy, because bisphosphonate,
okay.
I
like that.
It retains in your body for quite a while. The others go away. So if they're already gone, then what are you taking the holiday from, right? If it's no longer there. So I would even say it really is for, and the term was developed for bisphosphonate therapy.
I love it. I love it. And then, Anne, I know you and I were sort of chatting on the side about this nutritional question that came in, which I personally love as a vegetarian. I am always worried about, am I getting enough protein? Am I getting enough calcium? What's going on? Do you want to take a first stab at the calcium fortified soy milk versus cow's milk?
Sure. So, most of the plant-based types of milk are actually fortified with calcium, fairly equivalent to cow's milk. You have to evaluate the nutritional labels. And then it really comes down to, it's not an if or, it is a plus. So I think that calculator that Dr. Chawla showed us earlier is a great place to go. Okay, well, I'm going to drink, a glass of soy milk that has this much calcium in it. Do I need to also supplement with something additional? And then I think there's great literature out there about the types of calcium that is better tolerated for patients. Calcium citrate is often better tolerated for patients. It can be more expensive. And so calcium carbonate is an alternative, but that has some constipation with it. It's really about working with your patient to see where they're at, and always encouraging good diet. So things like egg yolks and mushrooms have vitamin D, green leafy vegetables have calcium. There's multiple sources to get these nutrients, and they're always better absorbed through food than they are through supplementation. But it's a balance of both depending on who the patient's at with their nutritional needs.
Thanks. Dr. Chawla, anything you want to add? Because I know that was a resource you suggested and something you have extensively taught me that I need to counsel my patients. I see them.
No, I agree with Anne, and I think it's more like getting patients off of calcium because they're so attached to that recommendation. That's what we were saying for a long time. Similar to aspirin, everybody was on aspirin, and so trying to explain that, well, this extra calcium is likely going to go to other places you don't want it to. So like calcifications and stones, and so really ideally get it from your diet as much as possible.
I'll piggyback on one thing that is that if anyone reads anything about soy and inability to absorb calcium in soy milk, that has been debunked, because there was some concern many years ago that there is a substance in soy milk that makes it hard to absorb calcium, but that's in a test tube. It's not been shown in humans to make any effect.
I love myth busting, so thank you. I appreciate that. A couple of questions are on deck side. I'm going to combine them because I think it's a really, it's a complex situation about, well, should I do it more often? Should I do it less often? How do I pick the right person? And what if they go somewhere else and I have no control over them? So the questions around DEXA screening. One is, do you anticipate that when you're transitioning a patient, let's say from their anabolic treatment, now they're going back to their bisphosphonate, because we are good primary care clinicians and we follow guidelines, does the frequency or the timeline of the DEXA change, or should we still wait that 5 years because now they're on bisphosphonate?
So this one's tricky, but I'll tell you why we do it early. If you're on, say, something like romosozumab, say it was every 5 years, no matter what, and then you sent them to me. I put them on 2 years of teriparatide, and then I sent them back and said, hey, they're good. I put them back on alendronate. Everything's great. And then you do a DEXA scan in 5 years after everything was started, and the bone mineral density is the same. Well, did it improve? Did it not improve and then it got worse? Or like, what happened exactly? And so this is why, from a practical standpoint, the most important thing to think about is I want to get a new bone density anytime I make a shift, whether it was a planned shift or whether or not someone broke their hip while on treatment and I want to do something new, because I need a new baseline if I'm going to start something new. Otherwise, I won't know, was the loss or the gain that I see in 5 years due to partially what was before, or is that due to something that happened after my intervention? And so just from a practical standpoint, that's really why the recommendations are what they are. But otherwise, if you only plan on doing something the same way for the next 5 years and you're not changing anything, the patient's stable, there really hasn't been shown to be a great evidence that doing it more frequently actually helps.
Because just because you're measuring it doesn't mean you're improving it. We're just measuring it. Got it. All right. And then I think the other topic, I want to go to Anne and Dr. Travla, because in the clinical standards committee that both of you sit on, we talk a lot about, well, how do we define age cutoffs, right? And should there be an age cutoff, not just of when you start screening, but when do you stop screening? Because there may actually not be significant benefit beyond it. And then a couple of years ago, Dr. Chawla was on our panel with the USPSTF chair at the time. So, first question, should there be a cutoff after which we say, you know, benefits are really outweighing screening for osteoporosis at this point? What do you guys think? No.
I would say no. So, you know, osteoporosis is one of those rare, not rare, it's one of those unique conditions where your risk of a fracture is indeed going to go up the older you get. And then especially those women who they're like, oh, but I live independently at home. I really just care about quality of life, so I don't want to do anything excessive. I counsel them that this is absolutely to maintain your independent quality of life, because as we have seen, if they sustain a vertebral or hip fracture, that is going to cause a rapid spiral down in their quality of life. So no, there is no upper age limit. I guess certain exceptions would be if they're completely, if they're on home hospice, if they're, requiring two-person assist for all their transfers and they're constantly monitored 24/7. That could be a shared decision-making, whether there's any benefit to be had by putting them through the scan, because just that whole effort of going through the scan is a lot in that situation. But for most other community-dwelling adults, no, I would not say an age cutoff.
Thanks. And I want to mention, just in the back of your mind, all of your ortho experience, because you're on the other side of it and receiving those patients. What are your thoughts?
So my thoughts are, you saw the statistics that basically 50% of folks that suffer that hip fracture are not going to get back to their previous level of function. And the mortality rates are actually quite high in each decile, starting after age 60. They just rapidly go up. And so to me, this is a quality of life issue. And if the patient in front of you, has a good quality of life, and we want to keep them upright and mobile, and also this is a confluence, falls are a confluence of lots of different issues, right? Dementia being one of them. All of those things will rapidly progress following that fall and any subsequent intervention. And one of the saddest things for me to have to do is, after we fix somebody's hip fracture, is tell their family, we can fix a fracture, but we may not be able to get this person back up and ambulatory again, because patients psychologically, they just sort of give up. They throw the towel in, and there's nothing that I or anybody else can do. And so we don't have to get there. I don't want repeat customers. I really don't. And so we have a lot of those discussions with families, especially when you start seeing those ground level falls. And you can look at bones via x-ray or in the operating room, and to have that discussion of, don't be caught up with the boxes. Look at the patient in front of you. And if all the indicators are telling you that this patient is fragile and they have osteopenia and it's going to get worse, our time to intervene is now, because that burden is significant. And I think we've all sort of gotten used to it. So if there's a take-home message that I can share with our audience today, don't get used to this. We have the silver tsunami coming. This doesn't have to be exponentially worse if we start to really speak to our patients about this now, do good screening, do good treatment, talk through the myths that have been propagated. I think we can really make a difference together.
Thanks.
And I would just like to add that if you actually go on the FRAX calculator, the femoral neck T-score is optional. So if you actually just put in someone's age, sex, weight, and risk factors, it'll still give you a score. And if you put in something like an 85-year-old woman with a BMI of 18, it'll probably tell you that their 10-year risk of a major osteoporotic fracture is above the 20% threshold. And I've used this on occasion for geriatric patients who had a hard time in the scanner to at least justify treatment. And so just understand that sometimes you can look at the patient and just kind of use common clinical sense, and that alone can really help you. And because it's really unfortunate when you just say, well, I don't have a DEXA scan, and then wait for that person to fracture 4 years later when they come in with a hip, replacement, and then you started. All right. So there are other ways to do it, but a FRAX score does not necessarily need that BMD.
Okay. I'm going to ask for rapid fire answers because I only have a minute or two with you all. So, alendronate versus abandronate, pick one, or both are equivalent.
Equivalent.
I pick alendronate.
Okay. Why alendronate?
Why? Because abandronate does not have as good, compared to vertebral fractures, the fracture might be a bit lower. Alendronate is great across the board.
Okay, got it.
But for insurance purposes, I don't know anyone, I don't think it's ever happened to me where someone said no to abandronate, or no to alendronate, yes to alendronate, but I wouldn't fight that battle.
Got it. Okay.
Yeah, but
so if you need to pick a battle, this is not the one that you want to pick. Okay, awesome. When we think about drug holidays, two questions. When do we check the DEXA? Is it at the end of that drug holiday? Or the other question around drug holidays, how long should it be? Like, should it be 5 years? Should it be 2 years? Should it be 1 year? How long are we doing this for?
So I would do the scan at the start of the drug holiday. So 5 years have ended on alendronate. I would do the bone density scan, and thereafter, depending on the results and the patient's risk factors for fall, for malabsorption, etc., I would repeat it in 3 years, typically. 2 to 3 years, yeah.
100% agree. And I would also say that what you're really looking for is, number one, absence of fragility fractures in the interim, and no statistically significant decline in the bone density.
Got it. Okay, so going back to Anne's point, look at the person in front of you. What's going on in their life, and make sure you're addressing them in their life, right? And Anne, rapid question for you. Fracture liaisons, hospital ortho teams, what are your thoughts? Yes, no, maybe so?
Yes, love it. And there was one in the chat from our mountain region. Your APPs, like me, are really great resources to run these programs for you. And it takes some interest and investment, but these can really decrease those downstream spirals for patients. So yeah, big fan of fracture liaison services. Can make a big difference for you, for the patients, for sure.
Okay, perfect.
And incidentally, Capture the Fracture is the name of the National Osteoporosis Foundation's efforts to create fracture liaison services, give resources, etc. So capture the fracture.
Awesome. And one takeaway that you want your friend, neighbor, loved one to know about osteoporosis. I'll start with Anne, Dr. Jiang, and then you can wrap it up, Dr. Chavla.
Lift weights, weight bearing exercise, go for a walk, lift weights.
Awesome.
I would say ask about fracture history. If you don't ask, they won't say it.
Okay, Dr. Chavla.
dietary calcium. And ask about alcohol, like really ask. Yeah.
All right, perfect. Okay, well, thank you so much. Dr. Greenswag, I'll yield the floor to you to close it out for us. We're not able to hear you.
There we go. Sorry. Oops, now my mouse just fell down. Thank you so much. This has been not just entertaining, but educational. I think people learned a bunch. And I think it's demonstrated by all the questions that we had and comments. And behind this group, certainly Dr. Chabla and Dr. Jang, Dr. Sagar, is a whole team of people who came together to do this work. And so we thank all of them. And we thank you for representing them. We understand that for primary care providers, I always say this is one more thing that we slather on, that another screening, but you can see from the data how important it is. So we really appreciate it. Anne, thank you so much. And we'll see folks again. Our next grand rounds is?
Yeah, we'll be sending the calendar.
Okay, great. All right. Thanks. Hope everybody has a great weekend, a safe weekend, and we'll see folks soon. Thank you so much.